Sorry, that's better. Hi there, good afternoon everyone. Welcome to this webinar. It's lovely to have you all here. I thought I had started the meeting there, but it transpired that I hadn't started it yet. So there was still, it was just myself and Liz and Ailey that I was talking to. So lovely to have you here. Please feel free to start populating the chat as to who you are, your organisation, where you work, or geographically where in the world that you are. None of us will take offence if there's people that are in slightly more exotic locations compared to sunny Dundee where I am. But it's so lovely to have you here. We'll get started in a minute or so. But yes, unfortunately your cameras and your mics are off, just so that we can kind of police everything within the webinar. I'm sure you've probably seen this kind of setup before, but please feel free to start populating that chat. We would love to know who you are and where you're from, and we'll get started in just a couple of minutes. Great, thank you. Okay, so good afternoon again, everyone. I'm very conscious of time, so we'll just get started. It's so lovely to have you all here, and thank you already to those who are populating that chat and telling us where you're from. It's so great to have you all here. My name is David Wilson-Wynn, or Dave. I'm the Senior Dementia Consultant within the Dementia Services Development Centre, and we are absolutely delighted to share with you this webinar of the phenomenal work that Professor Liz Forbat is doing. Professor Forbat sits within Social Sciences faculty. We are literally just across the road from one another, so DSDC and the Colin Bell building. So it's great to have Professor Forbat here sharing her amazing work. I'm not going to dive into too much detail about it because I'll let Liz do that. But this is just an opportunity as well, just to provide you with a little bit of an insight as to the work that we do within DSDC and why we're hosting these series of webinars. So hopefully you have heard of the Dementia Services Development Centre before, but we are situated within the Iris Murdoch building on the campus of the University of Stirling. And our job as DSDC is effectively to act as a knowledge exchange centre. So we bring together research informing practice, but practice also informing research. And my job as a senior dementia consultant is sometimes to provide aspects of teaching and training, but consultancy to clients all over the world. And we advise regularly on policy and strategy, not just to people within Scotland or within the UK, but you name it. We've probably been there or advised someone. So I'm not going to keep harping on. Please feel free to have a look at our website. This is a first in a series of webinars that we're hosting, and we're just absolutely delighted to have Professor Forbat with us. So I will hand across to yourself, Liz. Thanks so much.
Thanks, Dave. And hello, everybody. Really nice to see a wee crowd in here, and lovely to see where people are logging in from today. So shout out to Claire, who did one of our master's degrees recently. So I'm going to do a bit of advertising there, slip in a little link for anybody else that is interested in the course that Claire's done. But yeah, and always nice to kind of scan the list and see who's closest to campus, who's furthest away, and who's just around the corner from where I live. So welcome everybody. As Dave said, my name is Liz Forbat. I'm a professor of palliative care based at University of Stirling. You can see some of the campus here behind me in this image. But mostly what I'm going to be talking about today is about supporting residents in care homes to have better quality lives and deaths. So I've prepared some slides, which I'm just going to trot through with you. Some of these, one of them at least, is a video. So I'm hoping that whatever device you're on, you'll be able to see the video well enough. It's quite a small bit. I might have to come out of the presentation and go back in again to expand that as big as I can for you. Viewing pleasure. So I'm hoping now that if Dave could give me a wee wave that you can see my slide deck. Hey, thank you. Okay, we're off to an excellent start then. So I'm going to talk about this approach called palliative care needs round. So this is all about improving people's lives and deaths in care homes, and their work situation too, because we're really focused on what it's like for staff working in care homes. I can see loads of allied health professionals in the chat there, and it's really lovely to have you as part of the team here this afternoon. Because this really is about everybody that's associated with care homes, not just one particular sort of tranche of the staff group. So palliative care needs round is this very particular approach that got born out of realising and recognising just how complex things are in care homes. And it does feel like a bit of Jenga, where there's all sorts of bits that are sort of meant to fit together, but they're a bit wobbly. And then every now and again, somebody pokes one and it something falls out. And there's this kind of really tentative sense that things are going to keep holding together well enough. So we know some of the things that care homes are struggling with is about a kind of population size and the acuity, you know, how unwell people are. Population size is growing for people needing residential care for older age. We know that the population shift is only heading in one direction, and that people are more and more unwell when they reach residential care stage of life. By 2030, care homes will be one of the main places of death. So we kind of, I guess, think about death and dying, if we think of it at all, as happening primarily in hospitals, but actually these care homes are an absolute key site. We're also recognising that care home staff aren't necessarily always well trained and supported to identify deterioration and dying. We're working with care home in the midst of this sort of struggle between what's primary care and what's for specialists. And I think care homes sit at a really complex nexus of that, because actually care home staff really are specialists in looking after people who are much older and have got all sorts of complex health conditions, but they're working alongside primary care and secondary care at the hospitals, teams and so on. And that all becomes quite tricky about who's doing what to whom. So that connects with workforce issues and also about funding, about who's putting who into which spaces and who feels like their team's being kind of like sucked into other people's work. We also, of course, need to keep an eye on safety. We're often thinking about people in care homes and risk of medicines and complications from over-prescribing, and if there's opportunities to de-prescribe, thinking about safety around falls and those kind of things. Part of the care home context that also led us into this work around needs rounds was about the lack of adequate planning. Now we know that future care plans or advanced care plans, lots of people doing bits and pieces of work on that, and care homes often trying to do their best around that, and yet lots of people still towards the end of life not having documentation that really articulates what their needs, preferences and requirements might be. End of life medicines I've mentioned before in terms of prescribing and de-prescribing, but also access to medicines that might be particularly helpful in the last couple of days of life, particularly if people have got secretions or an exacerbation of pain or other kind of symptoms and so on. And then all sorts of other things about medicalisation of death. So I do a lot of work around palliative care, and that sits within a medical specialty. And so that sort of somehow frames death as being a medical phenomena, and it's not. It's a social phenomena. Well, maybe it is a medical phenomena, but it's also a social phenomena and something that happens within our care homes on a very frequent basis. Intersecting all of that is funding, or rather lack of funding. So all of these are these complex Jenga bricks where you're trying to hold the tower firm, but somebody inevitably is poking one of the bricks, and it's all looking a little bit fragile, but also really complex. So as a research team, and I was working with a bunch of clinicians in a hospice when we set off on this work, we were thinking about all of these as problems, all these things as something that really we could be doing something to fix. And if you take away two messages from this afternoon, one of the messages is that academics are genuinely invested in trying to make a change in the world to areas that we're passionate about. So this was driven by a sense of inequity that, people who are living and dying in their own homes, maybe they're 75 and had got advanced cancer, they're much more likely to get specialist palliative care teams, hospice teams coming in to look after them. But when you've got all of this complexity going on in a care home, often what happens is that the specialist palliative care teams from the hospice aren't that involved, or only come in right at the last minute when things have kind of hit crisis point. That's not good enough. So it was this real passionate desire to do something about this inequity that drove this work. So let me tell you what our palliative care needs rounds. So this is probably the most important slide you're going to see this afternoon. There's one important video too, but take kind of mental note of this one, I think, because this really summarizes it all. So needs rounds they've got three components to them. The first one, arguably the main one, and the one that we're going to talk about most over the next 45 minutes or so, is these monthly meetings, and they're staff only. So it's somebody from a hospice, your local hospice, and staff from the care home, and they sit together for an hour. It starts on time, it finishes on time, and it's only an hour to talk through residents where you are most concerned about somebody dying without an adequate plan in place. The conversation is led through with a checklist. I'm going to come on to that in a second. The checklist is free to use. All of this stuff is free to use. I will post links in the chat, and they'll be on slides so people watching later online can use those too. But essentially, a checklist talks you through a conversation about medical, sort of biological, psychological, social needs that residents have, to talk through medicines, about what might be added in or taken away, to talk about future care planning documentation, to cover off things around power of attorney. And throughout all of that, the specialist palliative care clinician is listening with an ear of, where can I insert some of my knowledge from the hospice sector into the care home, so that when we're talking about this resident, you can take that away as a small piece of learning. So that case-based education that's woven in just for a couple of minutes each needs round enables the staff to go away with that extra bit of learning. So what that looks like in practice is that one of these discussions might be talking about Margaret, who's 87, maybe she's got cancer and also dementia, diagnosed or not, and maybe some respiratory breathing problems. And the specialist palliative care clinician would be talking with and asking questions to the care home staff about what's going on for Margaret physically, psychologically, what's happening within the family, does she have support, does she have spiritual care needs, and so on. And then picking up on some of that, just weaving in a couple of minutes education that they've picked up through their specialist training through the hospice. That 1 hour meeting, people talk about up to 10 residents. 10 is a lot to get through. In some of our work, we manage 10 fairly routinely. What's happened over the years since we first developed this is that it's ended up being more like 6-ish residents that get talked about within the hour. As you can see, that's a very fast-paced turnaround. Even if you start on time and finish on time, it doesn't give much. So it's quite punchy and quite rapid, keeps the pace going, because we know care home staff are super busy. Okay, so that's component one, these monthly triage sort of prioritization meetings. We know, and we're focusing on the prioritization because you might have a care home with 50 residents, where we did some of the research. We were working with some of these enormous care homes that had about 160 residents. You can't talk through all of them. So we're thinking about who is most at risk of dying without a plan in place, and we're going to prioritize those. Okay, so that's component number one. Now, component number two often comes out of this one. So as you're talking through these residents, maybe the specialist palliative care hospice clinician says, you know what, it sounds like Margaret might need a referral. And maybe that's to specialist palliative care. Or maybe it's a referral to dementia specialists, or maybe it's a referral to an occupational therapist or physiotherapist or somebody else in the system. So the idea would be that from this discussion, they identify actually where the care home needs some specialist input that isn't there just yet. So those referrals can come on board. The third bit is case conferences, or sometimes these are multidisciplinary case conferences, and sometimes they're like family meetings. So what we found works well in the past is that case conferences to start with will be the hospice clinician, usually a nurse from the hospice, come in and sit alongside a member of staff from the care home, and then invite in other people. So that might be relatives, or it might be a GP, or it might be other people from the health or social care team. And the idea would be then to talk about actually what needs to be met, what other planning needs to be in place to get the care ready for this person's last days or weeks or months of life. As I mentioned earlier, all of this follows a published checklist. So that is needs rounds in a nutshell. The checklist, so I know this is quite small, so I'm going to zoom in a second so you can see it in a little bit more detail. So, and again, this is free. I'm going to drop a link into a website where you can download it. We'll start off on this little box here. So these are the triggers. So how would a care home know which residents to prioritise to bring forward? So again, let's say you're working in a care home with 50 residents. You don't have time to talk about all 50, and some of them might be relatively well. So thinking about these 5 things, and if you meet one or more of these, that would be a really good signal to think about popping their name on a sheet of paper in the staff room that says needs rounds at the top, and then popping down resident names underneath that then can be taken to the needs rounds when the meeting happens. Excuse me. So number one, the surprise question. Would you be surprised if this person died in the next month? Now, if you wouldn't be surprised, if actually you think the next 6 months might well be their last 6 months, bring them along to the needs rounds meeting. Bring along what you know about them, what your concerns are, and discuss them. 6 months out is entirely appropriate. Actually, did you know that with specialist palliative care, actually palliative care should be put in place from the moment somebody is diagnosed with a life-limiting illness? So whether that's dementia, COPD, motor neurone disease, or an incurable cancer, palliative care is absolutely appropriate from the point of diagnosis. It doesn't need to be the last few hours or days. In fact, we know that people live happier lives, better lives, and have fewer hospital admissions, and therefore cost the health service less if they get palliative care earlier. So this number one, the surprise question, is really important for the person's quality of life. Number two, so have they had an exacerbation of their symptoms? Have things got worse, or has their well-being declined? I can see a hand up in the chat. Do you want to pop something? Sorry, a hand up in the audience. Do you want to pop something in the chat there? Or do you want to, I don't know if you can unmute. So Dave or Ailey will let me know if you can unmute. I'll just keep going through these triggers, and then I'll see how that falls out. I can just see the beginning of your name. Is it Nicola? Nicola, yeah. Okay, so yeah, so have they had a deterioration in symptoms? If there's no plan for the last 6 months of life, so no advanced care plan, no future care plan, that would also be a good trigger to have this forum to discuss what's going on currently, what needs to be in place. Now, number 4, this happens all the time, usually at like 11 o'clock on a Friday night or on a Saturday night, and that is conflict with the family. So somebody, maybe Margaret, has had a fall or a stroke perhaps, and the staff don't know whether or not Margaret's family agree that she should be transferred to hospital or not. And quite often what happens is that you'll have one member of the family who says, yes, yes, send to hospital for everything. We need to prolong mum's life as much as possible. And another child, adult child, who will say, no, no, no. And quite often that conflict comes about when there hasn't been well enough kind of tailored and timed conversations about what to do. So conflict with family, a great other trigger. And finally, if they've been actually transferred into the care home, actively dying. So often that will be from hospital. So what happens next is if you run care needs rounds before you pop to the review section, but let's say that this is the first time through. So you go down through this list. So this is mapping out that biopsychosocial list of things to consider for the resident. So you trot through and the specialist palliative care clinician might ask direct questions, or the care home staff might just deliver this as part of their introduction to the resident. Oh, well, so, you know, this is Margaret and she's got advanced cancer and she's got COPD and she's got a dementia. Maybe she's got vascular dementia. And then there'd be a conversation. Well, what are their palliative care needs? So what kind of needs? What are you most worried about? What are your concerns about the goals of care not being met? What do you think is going to be most important to Margaret? What has Margaret herself said is most important? And then again, thinking through other people that are important to her. So part of that social kind of setting. Is there a power of attorney in place, and is that for welfare? So that somebody else can help be part of a conversation about choice and about what happens next. And that might also then pick up on conversations where there might be conflict within the family about what the goals of care might be. And as I mentioned before, weaving in a bit of case-based education. So quite often in all the research we've done on this, quite often the education that gets slipped in there are things like recognising dying and death. So we're not recognising death, that's much easier, but recognising deterioration that might lead to dying. Bowel management. So quite often, I don't know how many times I've heard this, the 5 Ps of delirium, thinking about, does anybody know what the 5 Ps of delirium are? Quick bit of case-based education into this session now. So the 5 Ps that might go through in this, if Margaret was feeling maybe more confused, you go through pills, pee, pain, poo and pus. So pills, has she had a change to medication? Because that can cause delirium. Pills, pee, how's her urine? What's the output like? Is there a particular scent to it? Slide has shifted. I'm not sure what that means, Julie. Should be on one that is part of the checklist saying new referrals. Pills, pee, pain. Is she in pain? Because actually quite often pain presents like delirium. Poo, how are her bowels? Is she constipated? I think seeing only half the slide's okay because I've zoomed in on it. Just because otherwise it's a bit too tricky to see all of it. If I zoom back out, that should have reset it for you. Pills, pee, pain, poo and pus. So has she got an infection? So then you might look at some sort of infection markers and maybe taking temperature, those kind of things, just to start to get a handle on it. So that's the kind of case-based education. You can see I've trotted through that breathlessly in about 1 minute. So it's that kind of education that the hospice staff might do with the care home staff, just to give them a bit of a sense about Margaret, but also other care home residents currently, but also in the future. So take that away. 5 Ps for thinking about delirium. Okay, so that would be the main part of the needs round for that resident. Then we go to the bottom of the checklist, to the action section, where you'd be thinking about, well, is there a need to review anything? So for example, reviewing medication. I'm going to scroll in a bit, so you're going to miss some of the checklist again. So medication reviews, adding some in, maybe taking some away, like there's no need for somebody in the last few days and weeks of life to be on statins. Do you need to organise power of attorney, advanced care plans, all of these kind of things? And then also, as I mentioned on the previous slide, is there any need for like external referrals and so on? So that is the checklist that is trotted through on these needs rounds. What I'm going to do now is I'm going to play this video. You can see just a tiny nugget of it here in the corner. If I try and make it any bigger, it all goes quite wonky. So hopefully you'll be able to see enough. For those of you watching on a larger screen, and for people watching later, Ailey's going to post the link online and you'll be sent a link to it. You'll be able to see little subtitles or captions which show which bit of the checklist the clinician is attending to as she goes through it. We filmed this in Australia. The woman in red is a advanced nurse practitioner from the hospice, and everybody else works in a legit care home in Australia. They were amazing. They're not actors, so keep that in mind as you're watching them, but that they're all doing this out of the kindness of their hearts to help us communicate with you about what needs rounds look like in practice. So I'm going to start the video a couple of minutes in, and we'll just watch it for a few minutes just to see what it feels like and how the conversation goes, and to mark out some of the pace at which this is done. So let me just skip to about 2:16. That might be as close as I can get it. Oh, there we go. Okay.
Who do you want to talk about first?
This case, Beryl, she's 92 years old and she had heart failure.
And what triggered you to talk?
Dave, can you just give me a thumbs up if you can hear that audio?
Can certainly hear it.
Oh, brilliant. Thank you. I'll keep playing them.
No
So
worries.
she's just initially asking about the triggers for discussion here, okay?
Talked about her today.
She's not eating or drinking that much, and she had difficulty breathing, and I think she had a bit of dementia. I'm worried about her.
So you're concerned about her breathlessness, her oral intake, and her general deterioration. Would you be surprised if she died in the next 6 months?
No.
Do you think she can make decisions for herself?
Yeah, she is adamant that she doesn't want to go to hospital again. She's tired and isn't scared of dying. Her daughter keeps telling her she has to keep trying and she needs to go to hospital to get better.
Who's her legally appointed alternate decision maker, and who's her family?
Her daughter and son have joined enduring power of attorney, and they can act together or separately. Her son is currently in Japan right now.
Does she have an advanced care plan?
No, she doesn't. Yeah, and a couple of weeks ago, she couldn't breathe, and the agency staff member called the ambulance. And because we don't have anything in place to make her comfortable, so we have to send her to the hospital.
She went to hospital when clearly she didn't want to. That must have been really hard for all of you and her. Okay, let's see what we can do for Beryl and you as the team, so that we can get a better plan in place. So you're worried about her breathlessness, her dyspnea?
Yes, she can't breathe.
What have you noticed about Beryl when she's breathless? How does it affect her?
She's really scared and panicked. It's very hard to get her to shower, and she started to wee herself. She couldn't make it to the toilet. She's very uncomfortable.
That's really common with people living with breathlessness. How do we support a resident who is breathless? And remember, if I ever ask you any questions that you don't know the answer of, that's okay. This is a safe place.
Sorry, Nikki, I can't remember.
The most important part of your job is to reassure her and be there for her. If she feels supported and feels like she can trust your care, managing her breathlessness will be so much easier, and she'll feel safe. And I know you already do this really well. To help her, we can use pharmacological and non-pharmacological approaches. When we talk about non-pharmacological, what we're speaking about is using a fan in her bedroom. We can use a handheld fan, a ceiling fan. We can always make sure that she has her oxygen on and wears that in the bathroom, and that we keep the doors open when she's having a shower.
Yeah, so we're keeping the air moving around her.
Exactly. And let's think about medicine. Firstly, it's important to look at the cause of the breathlessness. Is it the COPD worsening? Is it an exacerbation of that? Or is it lung cancer progressing? Or is it a new problem like an aspiration pneumonia or anemia, heart arrhythmia, or a pulmonary embolus? Once we've worked out what the cause is, then we can also work out if we can reverse that cause. And in line with the goals of care, does that mean going to hospital, or does that mean staying here and having treatment? Medicines we can use are antibiotics, steroids, Lasix, opioids like morphine, and anti-anxiety medications. Let's talk about opioids. Did everyone know that they're not just for pain?
No.
Well, we now have good evidence to suggest that opioid medication is really helpful in managing breathlessness, and it tends to break the panic cycle. So we use long-acting tablets or immediate-acting morphine.
I worry about using medication like morphine because I think it could cause addiction, and they hasten death.
Great question. Morphine used in low doses, orally and subcutaneously, doesn't reduce the respiratory drive. It's actually quite a safe medicine. People can become tolerant with it, but if people have pain or breathlessness and it has a job to do, it is an addictive. We do have to monitor a number of side effects. The biggest one is constipation, and we know that that's a big problem with this population of people.
Okay, so I'm just going to stop the video there, partly because we've just got back onto bowels, and maybe spend too long of my life thinking about people's bowels. Anyway, so what you could hopefully see there was her working her way through bits of the checklist. You got a little bit of her case-based education based on the resident that the staff wanted to talk about, and you can see how that all kind of flows. Quite low-key, but very focused. That video is available in its entirety for free on the web, so links available. Okay, so what next? So I want to let you know that although there's loads of different ways of supporting people in care homes, of all of the approaches that exist, this is the one with the strongest evidence base. So there are other things like gold standards framework, there are PACEs, there's various bits and pieces. This one has an extensive evidence base, which means that we've basically been pulling our hair out doing research on it for years on end. So there's all sorts of wacky words thrown into this. So I'll give you the kind of normal version of what all this means. So this first one, basically, we ran needs rounds and then had to compare with some other people from historic documentation to see what impact it had. This one, an ethnography. So to get that checklist, basically I did tons of observation, like fly on the wall type observations of loads and loads of needs rounds, and distilled from that what all the key components were. We ran this stepwise randomized control trial. So essentially what we did was we got a whole bunch of care homes signed up to do it. And, in a traditional trial, like half the people get the new thing and half the people don't. Well, this was a bit different because we knew by this point that needs rounds worked. So instead of splitting them into you get it or you don't, everybody got it, but people got it. They started at different times. So we started the first 2 facilities in January, the next 2 in March, the next 2 in June or something, and then just kept going until everybody was getting it. We did that study with 1,700 residents in care homes. And that's one of the main studies that we did. It was very, very robust. Implementation study. So the idea of this kind of study is about finding out what works for whom, under what circumstances and why. So it's all about not just doing research in a very controlled environment, but using it in practice. And then we've done other studies like what's it like if you do it just over Zoom or over Teams. We did some of that work during COVID. What's it like if you deliver it into very remote and rural places? So again, some of that was in Australia, and we did some interviews with people using it there. And then there's been other research done by teams that I'm not involved in, where instead of having a nurse delivering it, they've had GPs and other healthcare clinicians delivering it. And essentially, all of this works really quite nicely. And I'll chuck up in a second some of the evidence for that. So one of the things that hospitals are always really interested in, and governments, is what impact does this have? So here, basically through that trial, where we had 1,700 care homes, that eventually, 2 at a time, we rolled them into getting needs rounds, we saved $1.7 million, which is about £1 million, thereabouts. So it's phenomenal. And we were managed to do that because people spent less time in hospital, and the more nights you spend in hospital, the more expensive it is, right? So I can't remember what the current cost would be, but let's say it's £800 a night. Then the more time you can keep people out of hospital, the greater cost saving that is. Now, obviously, that's also much better for the care home resident if they can be looked after within their care home by staff that know them well and in a place that's comfortable and accessible and is very familiar, and particularly for people with dementia, where, a change in care location can be really, really bad for making their condition worse. So shorter stays in hospitals and fewer hospitalizations overall. Whoops, wrong slide. So big cost savings, making governments super happy. We also measured, what's it like for people's quality of dying? So we had some questionnaires that staff completed about how they thought people's deaths were. And that also improved. All of these numbers basically show improvement over time, meaning that as the study went on, more and more people were having good quality deaths. And that really matters. It's not like having a birth plan where maybe your first birth doesn't go to as you thought it might. You only get to do this once. So making sure that the death is as good and as dignified and as calm and in the place that somebody wants is absolutely critical. It's important for the resident, it's really important for the staff, and it's really important for families too. Other differences it made, so we had more advanced care plans or future care plans completed, a ton more as the studies have run on than at the start. More people dying in their preferred place, which on the whole was people's preference was to die in the care homes. So again, that links back to the kind of keeping people out of hospital when appropriate. I mean, we never said never ever send people to hospital, because sometimes it really is required, but where it's not appropriate, keeping people out of hospital. It does work as telehealth, so delivering it on Zoom or Teams or one of those platforms works really well, and was great during COVID, but also is really useful for other infection control periods. So you'll know yourselves that the norovirus pops its ugly head up about this time of year. So when you just don't want other people coming into your care home, this works really nicely. And what we've also found from the evidence is that it typically works better if it's a nurse from the hospice doing it, not a GP. The evidence around GPs tends to be that actually getting the relationships and getting it systematized is much more tricky than the nurse. It's also, of course, different knowledge bases, isn't it? If you think about GP's knowledge and training versus somebody working in a hospice as an advanced nurse, then they're bringing different things to the conversation. Both incredibly skilled professionals, but what we found for needs rounds is that it does work better with a palliative care hospice nurse. That one of the studies we did, which was about that implementation science, so what I described as being what works for whom, under what circumstances and why. When we did that study, we did that in a number of places across the UK. These were the key things that came out of it. So needs rounds influence staff confidence. So staff were more confident in the care homes to look after people using a palliative care approach. That was phenomenal. It improved care planning. It strengthened relationships and trust. So prior to needs rounds, the relationships between care homes and hospices was pretty tentative. The hospices would sometimes be involved, like at the last minute or where there was a crisis, that kind of stuff. But actually planning needs rounds and having them every month, start on time, finish on time, very predictable, actually built up a huge amount of trust between the two organisations. So protected time to collaborate, very resident-centred, and enabling some of these outcomes that we've talked about before. For Scotland, and I can see there's people from across the UK here, but for Scotland, the needs rounds approach ticks off something like 32 of the recommendations from the healthcare framework for care homes, including some of the ones that you can see, or all of the ones up on this slide, but also some other ones. So you can see that through this building trusting relationships, through the provision of case-based education and so on, the staff in the care home get extra bits of training. They don't need to go off to a full day course, because who's got time for that, and who's going to backfill? That's really difficult. But through these very short and punchy interventions, staff are feeling valued. They get a little bit more training and education. It supports the multidisciplinary working, not just with the hospice, but also linking in some of these other organisations or teams that you might refer to. Family feel more involved. The learning can get shared not just by whoever's in the needs round, but the staff in the needs round, but maybe at handovers and in the residents' notes. So you think back to the example that Nikki, the clinician in that clip, was saying was about morphine, and that morphine can be used as an approach to managing breathlessness because it breaks the panic cycle. Do you remember her saying that in that? So supporting, sharing, learning that. Imagine going and telling a colleague that right after this. Why don't you do that? Right after you finish this session, go talk to a colleague. The 5 Ps, pill, pee, pain, poo, and pus, and breaking the panic cycle with morphine, sharing the learning, and needs rounds helps facilitate that. You get the specialist support in place, the future care plan. You can see all of these absolutely critical things for all of our delivery, not just in Scotland, but globally. These are all absolutely essential. So you can see through this diagram that it's kind of like an onion model. So we've always got the resident at the centre of it. Of course we do. But you can see how this needs round approach impacts everybody. They get better quality of lives and deaths. The relatives get better informed and a much calmer environment for the person that they're related to. The staff feel more capable and competent to deliver palliative care in the care home. The specialist palliative care staff, actually, they get a really nice feedback loop from this and really enjoy working with care home staff. So that's really nice for them, and also enables the hospice to widen participation of people receiving their services, which is really essential for equity of dying and death, of good quality dying and death. Primary care gets impacted because some of this means that through the education, actually care home staff are asking slightly different questions, framing their questions with primary care and the GPs a bit differently. So one of the examples that we had was before needs rounds, staff would phone up the GP and say, you know, I think Margaret, she's a bit funny. She seems a bit, oh, I don't know, she's not quite herself. And the GP would be like, well, you know, I'm not really sure what the referral here is. After the needs rounds, the staff were phoning up and saying, I'm concerned about Margaret. We think she's got symptoms of delirium. We've screened for the 5 Ps, and we'd like you to come in and do some follow-ups on this, that, and the other. And so just having that kind of case-based education seeping into how care home staff are talking with primary care means that primary care then respond differently and are more responsive. And that's really important given how incredibly busy and under pressure that part of the services. And acute services, so basically keeping people out of ambulances, which are, I don't know how much that is at the moment, £800 or something is the average call out, you know, cost to the NHS. So ambulances, but also bed nights in hospital too. I'm going to skip over this one, but just a little nod to some of our fabulous research team in the UK, some of whom 1, 2, and 3 are experts by experience and were there involved in the research, giving their perspectives as relatives of people engaged in care home. We also had a number of other people who had relatives living and dying in care homes. So 3 members of the academic research team. I haven't got my face on here either, but anyway, 3 of us have got relatives, parents living and dying in care homes too. So that's part of the team, and also speaks to why we're really passionate about this. So I'm just winding up in the final few slides here, but I want to show you this wee jigsaw just as a way of depicting some of the different elements of the needs rounds approach and what impact it has. So you can see this one about supporting the care home staff, getting them a bit more of the full picture, and getting people together equals happy for everybody. Treating this as a way of making the care home the place to be, staff confidence, and enabling better relationships and outcomes for residents and relatives. Working together as an interdisciplinary team, so that's within and beyond the care home, aiming for better quality lives and deaths, and better quality care plans that enable everybody to do better, with education kind of threaded through with the tailored care. People love a quote, so let's chuck some quotes up at you. So I mentioned that we did some qualitative, some interview-based studies as well. So I'll just give you a second to read through some of these. I know some people will be joining on small devices, so I'll read out one, but leave you to read out some of the other ones. So I'll read out this middle one. We don't need to send somebody to hospital. We don't need to send somebody to the hospice. We can do it here. We need to have the confidence in the decisions we're making as a team and in our skills. So that was a staff member talking about how they were recognising through the needs round process that actually they can keep people in the care home. They don't need to have this kind of knee-jerk reaction where they dial 999 or week somebody off to hospital. They're now growing the confidence and skill set to do that themselves. I'll pick another one of these again, just for people that are on small screens or got visual impairments. So let me just think which one I'll go for. Communication, because that's absolutely the core. Communication and relationships at the core of everything, really. So there's been a lot of improvements with how we communicate with each other. Really helped. We sort of bounce off ideas from these needs round meetings, and we just all know so much more information and knowledge about how to care for end of life. So we all have different ideas that we can discuss with each other about it. So that idea that the education and the impact of this just seeps through all sorts of relationships and conversations. So it benefits everybody. And that means even residents that are never discussed in a needs round, because their information and the education and the approach shifts how care homes look after other people. Monthly might be a bit too frequent for some care homes, particularly smaller ones. And it does take time to set up. So keep that in mind if you're keen to get going with this. And I would really implore you to, and for anyone that's involved in inspection or support of care homes, to advocate for this to be used, to just frame it as needing a couple of months to get going. It's not kind of immediate, not like taking paracetamol for your headache where it's gone in 20 minutes. So it takes a wee while to get going. We've written so much about this. I'm not going to dwell on this, but all of these links are available on our website. Now, this is the website address, and I'm going to drop that into the chat for you. But people, oh no, that's pasted in a bit weird. So the link will work immediately from the chat, but for anyone watching again later online, this top line is the website, and that contains all of our resources, including the checklist, all the publications, the videos, the video that I showed you, but also some other little sort of starter kits to get needs rounds going. So please use those and keep in touch. Let us know how you're going, if you're adapting it, and what sense you're making of it. Quick nod to our funders who funded some of the research for this. Okay, I'm going to stop sharing there. And I guess hand over to Dave, who's going to then chair the floor for questions, queries, heckles, jokes, or anything else you fancy.
I'll try my best. No jokes from me. Thank you so much, Liz. I think I'd just like to, suppose, share my own opinion of this. It's incredibly reassuring to see what this work is, and I suppose actually being able to give, in my view, what is a tangible checklist. Is when I think about my practice and people I've supported, particularly within the care home sector, they often like something that in front of them they can use as that guide. And of course, what that ensures, particularly thinking about people who are living with a dementia, is that consistent approach. I like the fact that it's classed as a needs round, so it's specific to each individual person, which is so important. But the other part, just two very quick points, was around are all of our understanding of what the complexity of care will look like in the future, because we know that as we're aging, and also what I'm hearing from people within the sector is that actually by the time people move into full-time care, their dementia is at a far more advanced stage, and actually their overall care needs are far more complex even compared to 5, 10, 15 years ago. It's a completely different makeup, isn't it? And also, just to pick up that point that you mentioned, because it's something that I often speak about quite a lot, is we tend to find that the beginning of a care plan is very populated, but actually as we journey through the care plan, particularly that end point of where it discusses palliative and end of life care, is often not populated at all. So it's really quite essential, isn't it? That the good thing is that when we're looking at these prompt questions that start off the checklist, it'll just get people thinking completely differently, which is fab. This is just an opportunity to pop some questions or your thoughts within the chat if you'd like to do so. Nicola, I hope you're still here. Ailey is going to unmute you so that you're able to ask your question. Thank you so much for bearing with us. I should have probably said at the start that we were going to save questions until the end, or you could just populate the chat as we go through and I'll try and capture as many as we can. So, Nicola, are you there? And do you still have your question? The floor is yours.
Yeah, you never know if these are legacy hands, do you?
I know, that's the thing, isn't it?
Yeah.
Hopefully you'll be able to be unmuted.
It came up quite early on, so I can't even remember what I was chatting about at that point.
I'll maybe try and see if there's something that I can do.
Okay.
On my side as well.
And we have to hope Nicola's still there and we're not going to be eavesdropping on her talking about a resident.
No, absolutely. So, Nicola, I think what's just been popped in the chat is Ailey's mentioned that you now need to unmute yourself, but your mic has been activated. So we just need you to unmute, if that's possible, so you can ask your question. If not, pop it in the chat and we can move on. No, perhaps not. But like I say, Nicola, if you are about, just feel free to unmute, or if not, pop it in the chat. This is just, I suppose, the last kind of closing 5 minutes, that if you wanted to share your thoughts in terms of, particularly if you're within practice right now, what would this mean for you? What would this mean for staff? I think would be something that I would be particularly interested in hearing as well. Or if you just had any other questions, feel free to raise your hands, because we can unmute microphones, or as I say, pop them in the chat, and we're happy enough to facilitate any thoughts that anybody has. I'll leave it a minute or so just to.
Yeah, well, just keep in mind that on the website, you could just go have a look at some of the videos and resources, and do genuinely email me or anybody else in the team if you've got any follow-up questions or interested in it in any way. We quite often get people getting in touch saying, oh, this looks fine, but can we tweak it? Actually, I'd like to make an adjustment. And the answer to that is always yes, please use it. Yeah, but let us know, because actually I'm always going to be curious about how people are using it. Okay, so I can see a question from Michael. Can I ask, what is the response from palliative care specialists to them supporting local care homes? Oh yeah, so they absolutely love it. What we found in the Australia one was that it took off really quickly, and the specialist palliative care clinicians absolutely loved having this different group of residents. They were learning a lot. They were learning a lot from the care home staff about, for example, different dementias, a different kind of acute symptoms, and the different way all of those kind of interact, because it is a bit of a different client group to typical hospice patients. So they absolutely loved it. In the UK, I would say one of the things that the specialist hospice staff got most was that feedback loop of recognising how they were impacting care. And I think that was true also in the Australian research. But yeah, they absolutely loved it. Thanks for your question, Michael.
I think it's just the one question that has been asked a couple of times, Liz, is are the slides available for people to go back to? I know the recording will be on our website anyway, so people can see it that way. But there's a couple of people that have asked specifically if the slides would be available. But I suppose all the information contained within the slides would be available on the website in a combination of the recording. But
it would. I mean, what I can do is I can send Ailey the slides and maybe she can circulate them. And I'll see. I'm not very good at editing my own website, but I'll see if I can upload them there because I think that might be quite handy too. So yeah, great.
That would be
and somebody,
great.
Tina was saying about emphasize on end of life oral care. Yeah, that's interesting. I mean, that does sometimes come up in the case-based education. So one of the things that hospices quite often will suggest to people who are living and dying in their own homes is to do oral care with whatever the person really likes the taste of. So things like beer or that kind of stuff. So they might well introduce that into the needs rounds, depending on what the kind of education support topics are that crop up for people. But yeah, oral care is super important.
Absolutely. Louise, I think we've replied to you, but yes, the other webinars will be advertised on our LinkedIn. There's Sean who's asked if you have any examples of local hospices that have partnered with a care home in terms of funding.
Yeah, I'm not really sure how that's working in the UK. In Australia, they've had national budget measures which have put in place needs rounds. The UK, I think we need to have this embedded in delivery of the healthcare framework and in care inspector or care commission type approaches. So I think it's probably got to be that way round that then influences the funding. I think what quite often is a bit of a tricky thing in here is that the care homes are quite keen, but the hospices have a very kind of fixed model of who they deliver services to. So I think if you're working for anybody, write to the local hospice and say, can we have this? This is part of delivering equitable care to residents in your catchment, in your community. So I think it kind of has to come from there. I've tried really hard to lobby for funding and I've got not very far in the UK, but much further in Australia on that. So yeah, I appreciate the question, Sean. I think that's really important.
Absolutely. There's a question also coming as well as some feedback. I think the format you use would help community staff have conversations prior to ladies and gents moving into long-term care. I think that's such a great point because particularly where we're fortunate within Scotland to have post-diagnostic support, this is actually something that I think would be really well received within a post-diagnostic model, particularly when we're focused on, at the moment, one of the pillars being thinking about your future care and future decision making. It's often not a conversation people want to have right after the diagnosis, but actually having worked in a post-diagnostic team, the amount of people who were recently diagnosed with the dementia that would actually start talking already at that stage, not necessarily with family, but to a practitioner about their palliative care and what they wanted their end of life care to look like, what they wanted their death to look like was really important.
Yeah.
So actually, it is obviously it's something that we would need to consider. Julie's put in a piece of feedback, just it's a great approach, however, requires the buy-in of the wider multidisciplinary team to participate in the needs round, and also adequate staffing and provision of training in care homes, which is the consistent concern. So I take it out of interest, Liz, is within the website, I've not had a chance to have a look at it. Is there like a training module? Do you offer training in relation to the needs round? How can people access that?
Yeah, so the videos are intended to be the resource, and there's a frequently asked questions and kind of starter packs to get people going with all of the documentation that you might need to liaise with various partners. So all of that is available for free on the website. And if you can't find it, just email me and I'll send it to you. And so, yeah, and actually what we found is that because we integrate the training within the care home, when you're actually doing the needs rounds, actually it means less resource in a way, because you're kind of getting ahead of problems. The buy-in of the wider multidisciplinary team. So the needs rounds themselves typically are care home staff between 2 and sometimes we had like 8 or 9 people in the room, but that seems extraordinarily large. But usually only a couple of members of staff from the care home team and somebody from the hospice. So there's not a big need for a wider multidisciplinary team unless you get to that third bit of the checklist, which is about referrals to other organisations. Yeah.
Great. And Sarah's put some lovely feedback there in terms of this culture shift within care homes, which I think we all would be obviously always advocating for, and she's involved as a specialist trustee in supporting staff in their support of people living with a dementia. And in Sarah's experience, the staff are compassionate and they need to have the new tools that are there, are research informed and evidence based, sharpening their existing skills, and that she's going to suggest this as part of the care home liaison service, which is so lovely to hear.
Yay!
So, happy
Yeah.
day.
And get in touch, Sarah, if there's anything I can do to support that, and let us know how it goes, because that would be amazing. Thank you.
I'm very conscious of time. We're now a minute over our kind of scheduled time. Liz, if there's anything else from yourself before we kind of bring it to an end, if there was anything else you wanted to say.
Yeah, final parting shot is that one of the key things I've learned from this is just how amazing care home staff are. So for those of you in the room, thank you. Keep being fabulous.
Yeah, absolutely. And we echo that without a shadow of a doubt. Thank you all so much for taking the time to join us on this webinar. And thank you again to Professor Liz Forbat for sharing her incredible work. The recording of this will be available on our website. Please keep an eye out for that so you can watch it again. But also our future webinars that we will have coming up that will be advertised within the website and our social media platforms. But thank you all so much for your time this afternoon. Great to see you.
Bye.